I'm very pleased to be here. I was kindly invited to come last year, and I enjoyed it very much, but I didn't swim in the sea. But this year, the sea is nice and warm, and so I have enjoyed the Congress and swimming. So I'm going to talk a bit about the treatment of psychosis, but start by discussing the causes of psychosis so that we can treat the causes, not just antipsychotics. Everybody knows how to use antipsychotics, but to treat why people are psychotic. And just to remind you that there is a genetic contribution, and this is the most famous slide in schizophrenia in the last 10 years. And this is, well, there was a variant of it in 2014, but this is the up-to-date, the PGC Wave 3, a study of 75,000 people with schizophrenia and over 100,000 controls. Came out in Nature just over a year ago. Here are the different chromosomes from 1 right up to the X chromosome, and here is the strength of the relationship with schizophrenia. So it's called a Manhattan plot because all of these little skyscrapers, they're supposed to be like skyscrapers as in New York, represents a point on the genome where people with schizophrenia are significantly different than controls. You can see here, there's a huge, this is the strength of the association. You can see on chromosome 6, there's a very tall skyscraper suggesting around the HLA, the immune area, that there's at least one important gene for schizophrenia, and many people would think it's a complement gene. But you can see that there's lots of these little genes. When I was young, it was thought that perhaps there was 1 or 2 genes for schizophrenia, but now we know there are lots and lots. And so there are at least 263 points on the genome where people with schizophrenia differ from controls in terms of what are called single nucleotide polymorphisms. And one of the reassuring things about all of these genes is that they're expressed in the brain. Here, this is going back to an earlier study. This is 2014. This is the most recent one. And here you can see where the genes are expressed, and you can see that they are in the brain, in the frontal cortex, and right down to the cerebellar hemisphere, the caudate, the hypothalamus, and then they're not expressed hardly at all in the rest of the body. So sometimes people say schizophrenia is a whole body disease. It isn't. It's a disorder of the central nervous system of the brain, and the physical consequences are secondary to the illness and its treatment, but they're not actually part of it. So the associations are enriched in neurons and those genes involved in neurodevelopment, particularly in glutamatergic genes, glutamatergic neurons in the cerebral cortex and the hippocampus, and also GABA interneurons. And if you remember that dopamine is very central to schizophrenia, and what controls dopamine, glutamate and GABA. So it's relevant that many of these genes involve glutamate and GABA. Now, one of the clever things that you can now do is you can take all of these little genes that are associated with schizophrenia and add them up and produce a polygenic risk score. This is just the summarizing a paper from Catherine Lewis and Evangelos Vassos. So you take the blood, you extract the DNA, and then you do a genome-wide association study, and you look at where your patient differs from controls. And in some people, there will be lots of points, lots of genes where the patients will differ from controls, and in other cases, there'll be far fewer. So you can get a polygenic risk score for schizophrenia. So all of us can get a polygenic risk score for schizophrenia, and some of us will have no predisposition at all practically, and others may have quite a high predisposition, or vulnerability rather, but will never manifest the illness because we do not encounter the environmental factors that precipitate the illness. So you can measure in patients and in controls. Some of you will have sent off your DNA to Ancestry or to 23andMe, and you can actually get, when you get the results back, if you take them to a geneticist, they can tell you what your polygenic risk score for schizophrenia is if you're interested. I don't care because I'm long past the age of risk for developing schizophrenia. What genetic disorders do you think I would be worried about? When I sent off my DNA, or my wife did it as a Christmas present, I sent off my DNA to 23andMe. What disorders do you think I would be worried about?
Parkinson's.
Yes, Parkinson's disease, no susceptibility. Any others? Alzheimer's disease, fortunately no susceptibility. Anything else I would be worried about?
Prostate cancer.
I never looked at that. And something I was much more worried about, I was worried I might have some English genes. Because I'm Scottish, and fortunately my genes are more Irish and Scandinavian rather than English. But anyway, we can all get a polygenic risk score for schizophrenia, and we can also get polygenic risk scores for bipolar disorder and for depression. So what we were interested to know was, if you take a whole series of people with psychosis, people with schizophrenia, people with schizoaffective disorder, people with bipolar disorder, how will these different scores, these vulnerability polygenic risk scores, how will they map onto the actual disorder? And this is a PhD thesis just done by Vicky Rodriguez, who's a PhD student from Spain, and again Vangelis Vassos as a collaborator. So we had about 1,200 patients with psychosis from a study called the EUGI, which I'll come back to later, and 1,200 patients and about the same number of controls. And so we got them GWASed, and then we calculated the polygenic risk score for schizophrenia, which is in blue, the polygenic risk score for bipolar disorder, which is in red, and the polygenic risk score for depression, which is in grey. And so, as you would expect, the people with schizophrenia or schizophrenia spectrum disorder, they scored highly on the polygenic risk score for schizophrenia, which you would expect. But interestingly, they also scored quite highly on the polygenic risk score for bipolar disorder, and a little bit on the polygenic risk score for depression. The patients with bipolar disorder, surprisingly, they actually scored higher on the polygenic risk score for schizophrenia than they did for bipolar disorder, and depression was still quite low. For depression, there was very little in the way of risk for schizophrenia, quite a lot of risk for bipolar disorder, and the greatest risk for depression. So essentially what we're learning is that the genes don't fit neatly onto our diagnoses. Kreppelin suggested that schizophrenia and bipolar disorder, what he called dementia praecox and manic depression, were entirely discrete disorders. But they're not. They overlap. That one of that people with schizophrenia have quite a lot of susceptibility, bipolar susceptibility, and people with bipolar disorder have quite a lot of schizophrenia susceptibility. This is one of the reasons why it's so difficult to distinguish between schizophrenia and bipolar disorder. I'm sure you've all come familiar with the case where there's a patient has been admitted to hospital 5 times and sometimes been given a diagnosis of schizophrenia and sometimes a diagnosis of bipolar disorder. And this confuses the patients and it confuses the relatives. I can think of a patient who had been admitted to hospital 8 times, and I saw him with a junior doctor, and I said, what was the diagnosis been? And he said, well, on 3 occasions he had a diagnosis of schizophrenia, and on 3 occasions he had a diagnosis of schizoaffective disorder, and on 2 occasions he had a diagnosis of bipolar disorder. And I said, that's ridiculous. Who were these silly psychiatrists who diagnosed them as having schizophrenia? And the junior colleague, his mouth began to twitch a little, and he said, well, Professor Murray, I'm sorry to say that you were one of those doctors who diagnosed them as having schizophrenia. Now you say he's got bipolar disorder, but in the past you said he had schizophrenia. So it's not that we are useless clinicians, it's just that one disorder merges into the other, that they are not totally discrete. So 2/3 of the genes for schizophrenia are shared with bipolar disorder and at least 20% with psychotic depression. Well, so much for genes. We come now to women's fashion. Ladies, why am I showing this slide? What kind of fashion is this? You know that this year, at least in Western Europe, very bright colours are the fashion. And what is it called? This is dopamine dressing. So during COVID, the fashion industry it collapsed. Nobody is buying clothes at all, and everybody's a bit depressed. After COVID is finished, the fashion industry says we need to cheer everybody up. We need to have bright clothes. And then some clever person in the fashion industry said, well, this is colourful clothes are giving a reward. What is the basis of reward? Oh, it's dopamine. So they call this dopamine dressing. So if you go onto Google at the end of this lecture and look up dopamine dressing, you'll see lots of coloured clothes like this. So if there's one thing you learn in the lecture, at least for the ladies, it's dopamine dressing. So if the fashion industry knows about dopamine, we need to know a little bit about it as well. And of course, you all know that when people are acutely psychotic, they have an excess of dopamine in the striatum. So you give a dopa, fluorodopa, a radio-labeled fluorodopa, and it's concentrated in the basal ganglia, and you can see that people with acute schizophrenia have increased dopamine compared with controls. Lots and lots of studies have shown this. But we've known about this for 50 years, that why should having too much dopamine in a bit of the brain, in the associative striatum, why should that make you think that the man down the road is trying to poison you? Or that the CIA are trying to put a chip in your frontal lobes? What is the connection between having too much dopamine in the striatum and having these abnormal beliefs or hearing voices? Well, here we need to come to prediction error. And actually, I was very pleased to hear Femi Oyebade talking earlier today about prediction error and also about perception. So we learn and update our beliefs through prediction error. We constantly predict what we do expect to happen in our environment, but if this doesn't, this will result in surprise. If I show a next slide, you expect that, so you don't release any dopamine. If I fall off the stage and land in a heap, this is a surprise. You will release dopamine. I'm not intending to demonstrate this. So dopamine neurons fire to unexpected events, but not to expected events. So the dopamine firing facilitates our learning for experience. So if something very striking happens, dopamine is released, it grabs your attention, and you often remember that particularly strongly. So let me give you an example, if we can have the first video. Everybody awake? Yes, video. Dopamine. 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 No dopamine. It's okay, can we go on? Can we stop it? So these people are seeing an extremely unexpected thing. When they went to, I guess they knew there was a movie being shown, but when they went there, the one thing they didn't expect to see was a pink elephant. If after the lecture you go out and you are thinking of walking down to the beach, and as you're going down towards the sea, you see a whole series of pink spotted elephants going by, this will grab your attention. You will remember it all your life. You'll think, why wasn't I in Antalya that day that I saw the pink elephants? Was there a conference? Yes, I think there was some old British chap talking about schizophrenia. But you won't remember anything I say, but you would remember pink elephants because the dopamine is released and that embeds the new learning. You would learn that you go to Antalya, you can see pink elephants. Of course, it seems unlikely, I think, that this will happen. But when you look at people with schizophrenia, they have abnormalities of prediction error. They are not good at predicting. They make mistakes in predicting. And there's a number of studies that have shown this. This is particularly from the group in Cambridge, including my son Graham, who is a professor there. And so people with schizophrenia, even before they get antipsychotics, show abnormalities of prediction error. And this is related to dopamine. Striatal dopamine has been called the wind of psychotic fire. So unmedicated patients, long before getting antipsychotics, they show prediction error abnormalities and they show excess dopamine signaling. They're synthesizing too much dopamine in their associative striatum, and this leads them to think all sorts of things which are not important are very important. So unimportant things, the way somebody looks at them, the color of, maybe some of you who came to the conference by car, I wonder if you remember how many red cars you passed. Nobody knows how many red cars, but to a person with too much, is releasing too much dopamine, red may mean danger. They may notice all the red cars and think there's a conspiracy going on and somebody is following them. So this excess of dopamine leads to excess salience, and the person who popularized this is called Satish Kapoor, who popularized this theory in 2003. But actually, the basis of the theory had been worked out by Geoffrey Gray in 1991. And he said that when you've got too much dopamine, then meaningful connections are created between temporary coincident external expressions. So if one thing is happening and another thing is happening, you put the two together. Or perceptions with thoughts that happen to be present. Or you see something and you're thinking about something else at the same time. Again, you can put these two together. Events and recollections that happen to occur in consciousness at the same time. Because the dopamine is, it makes things feel so important that you tend to either think, well, these amazing things are happening to me, I must be very important, and you feel manic. Or alternatively, you think these very important things are happening to me, somebody is out to get me, and you become paranoid. Now, of course, antipsychotics can normalize this dopamine dysfunction and the abnormal learning. But if the striatal dopamine is not normalized, the persistent abnormal experiences and delusional thinking seem to colonize the mind. And in some ways, the abnormality early in the course of illness is in the striatum, but the longer you have these abnormal beliefs and the longer you hallucinate, the more you develop cortical explanations for them. So you get delusions embedded in your cortex. And so that even if the striatal dopamine abnormality is normalized, you can still have the belief. I imagine you've come across patients who said, the CIA were persecuting me for years. But 3 months ago, actually just when I started on the antipsychotics, it seemed that the CIA stopped persecuting me. And they haven't been persecuting me for the last 3 months. But I know they were persecuting me before. So they still have the delusional memory, and no amount of antipsychotics is going to erase the memory. So one of the interesting things is that once you've heard a voice, most of us don't hear voices, so we're not looking out for a voice. But once you've heard a voice, or once you hear somebody calling your name, or a voice saying something unpleasant to you, you're more on the alert. And if this happens to you, a lot of times, you almost expect to hear a voice. And the expectation may actually outweigh the environmental stimuli. So, for example, I have a patient that I've been seeing for 25 years. She's actually a doctor. And she doesn't hallucinate in the absence of any noise. But, for example, when our fridge begins to buzz, when the electricity comes on in our fridge, she'll hear the buzzing, and after a little while, the buzz turns into a voice. She is listening in the buzzing noise, half expecting to hear a voice, and then her expectation is fulfilled, and she actually does hear it. Similarly, I have a patient who is particularly troubled by planes. When a plane is coming over, he hears the drone of the plane in the distance, and then as it gets nearer and nearer to him, it gets louder and louder, and then the noise of the plane turns into a voice. So it's not uncommon for voices to be precipitated by some noise, because people are then sensitized and they're looking, or they're searching to see if there is a voice there. And this theory has been put forward particularly by Phil Corlett, who used to be in Cambridge, but is now in Yale. And he says that hallucinations arise when strong prior beliefs exert an inordinate influence over the inferences we make about our environment, creating perceptions where there are no corresponding stimuli. And again, in his lecture at lunchtime, Femi pointed out that there is a difference between a sensation. You may have a sensory input to your eyes or your ears, and that's the sensation, but what you actually perceive is the brain modifying the sense and interpreting the sensations. And we usually get it right, but we don't always get it right, and sometimes our prior beliefs may cause us to falsely conclude that there is a stimulus there when there isn't. Let me give you another video too. You may think that, well, patients' beliefs about their environment may shape their perceptions, but this doesn't happen to me, does it? What about the rest of us? Do our expectations shape our perceptions? Can I have the next video?
This is the hollow head. Actually, at the moment, it's a perfectly normal head of Charlie Chaplin, but wait, as it comes round, you'll see, or will you, that it's hollow. The back of it, coming round now, is actually a hollow mask. appears to rotate in the opposite direction, and amazingly the nose sticks out, although it's actually sticking in. Coming round now is the normal, correct as it were, face, and wait again as it comes round, and you'll see this extraordinary thing like Jekyll and Hyde. Both the noses stick out because it's so unlikely that a nose sticks in that a face is hollow. So you see it as convex, although it's in fact concave, as now, and then it'll become the normal face again, there. And note that as soon as the features appear in the hollow inside, it will look convex, as though it's a normal face almost, though it isn't. As soon as the features appear, there, your brain refuses to see it as hollow simply because it is so unlikely. And this demonstrates the immense power of top-down knowledge, which will actually counter signals bottom up from the senses and force an extraordinary illusion in which the sensory information of the present is cancelled by immense knowledge derived from the past, because you've seen so many faces, all with their noses sticking out. So it's just impossible to see that as correctly hollow.
So, did anybody not see the two faces? So everybody saw the two faces. So I have seen this video, I don't know, maybe 50 times. And I say to myself, every time I see it, I say, this is a hollow face. Brain, you know this. This is the same as you saw it the last time. Can you not understand that there are not two noses sticking out? It's a hollow mask. But my brain still refuses to believe that it's a hollow mask. So I still see this abnormal perception because it's my belief. You cannot see the inside of a face. And so it indicates that what we actually perceive is overruled by what we believe. And this is what Corlett says, that once you've actually heard voices, once you've had the experience of the hallucinations, then you're so alert and you believe so strongly that it's possible that you could hear voices, that sometimes you hear voices when of course there are no voices there. So anyway, so much for the role of dopamine in psychosis. And of course our treatment has relied on D2 blockers, either full blockers like risperidone or partial agonists like aripiprazole or brexpiprazole. So, and in some ways, our treatment is aimed at the D2 receptor, but the abnormality is actually in the presynaptic dopamine. So there's too much dopamine being synthesized and released and hitting the receptor. And we can't really do anything we've not been able to do anything about the synthesis of the dopamine. And this causes the psychosis. But what we do is that we block the D2 receptor. So we're not actually addressing the primary problem. We're addressing a consequence of the primary problem. And of course, for 50 years, that's all we've been able to do. We've had all these different antipsychotics, but they all work in the same way. But fortunately, we're at a point where there are now new antipsychotics coming along which don't seem to have the same effect, or that don't seem to operate on the D2 receptor. As you can see, blocking the D2 receptor diminishes the psychosis, but it causes a lot of other side effects and problems. So there now are new antipsychotics which don't directly block dopamine. So one is a TAR1 agonist called ulotarant, and this decreases the uptake of dopamine into the terminal, reducing the presynaptic dopamine levels. Let me go back. So it's actually directed here rather than here. And this is from the phase 2 study, and this is just to show that this is in people with schizophrenia, you can see that the people who were on the placebo here, they get some improvement, but the people that got the TAR1 agonist improved significantly more than that. So this is a good demonstration. This was in the New England Journal of Medicine, and it's quite likely that this is about to be presented to the FDA. So it's quite likely that it'll be in clinical practice soon. And there is a second type of new antipsychotic, which is a muscarinic cholinergic agonist, M1 and M4 agonist. Now, these kind of drugs have nasty gastrointestinal side effects. But a very clever pharmacologist thought, well, could we block the peripheral effects of the drug, but not block the central effects? So could we take something which doesn't cross the blood-brain barrier and give it so that it would antagonize the muscarinic effects in the periphery, but wouldn't antagonize them in the brain? So this is what we now have. We've got xanomeline and trospium in a combined drug. And again, this is just to show the effect. Here is the effect of placebo and the positive symptom score. Here is the effect of the combined muscarinic cholinergic agonist and the peripheral antagonist. So it's a very clever notion. And by blocking the peripheral effects, you get rid of most of the gastrointestinal side effects. So this is another option that seems to be about to come. So after all these years of relying on D2 blockade, it does seem that within the next few years, we're going to have two alternatives. So if we come to, we tend to think of schizophrenia like psychosis, as an entity. And there have been various attempts to try and subdivide it. For example, people do MRI scans and say that particular type of MRI scan is a subgroup. And other people say, well, we'll do cytokines, and people with inflammation, they may be another group. But none of these attempts to use biological markers to subdivide people with schizophrenia has proven to be of any value in patients' treatment. Now, but in the last 15 years, it has become widely accepted that environmental factors increase the risk of psychosis. We talked about genetic factors already, but environmental factors there are obstetric complications and other developmental events, nasty things that happen to the brain of the growing fetus and child. Or then there is social adversity, so people who are exposed to child abuse, people who are migrants or ethnic minority status, or people who have adverse life events, so social adversity in general, and then people who abuse certain drugs. So these are the three big etiological types. So if we think that how do these different factors operate, it turns out that they all operate on the dopamine system. So genes, obstetric events, drug abuse, child abuse, and stress all induce striatal dopamine dysregulation. So dopamine dysregulation is the final common pathway to psychosis in the vast majority of cases of psychosis. Now, if you think, most of you are medics, I guess, all of you are medics. If you think of coronary artery disease, the final common pathway is a clot in a coronary artery. Now, you try and get rid of the clot, and now you can have surgery, or you can have a graft, or you can take out the clot. But the important treatment to prevent another episode involves looking at the causes. And the causes include familial hyperlipidemia, hypertension, smoking, obesity, and lack of exercise. So the physicians, they don't just get rid of the clot, and then tell people to carry on smoking and carry on taking no exercise. They address these questions, and they give a statin to decrease the cholesterol. They give hypotensives. They give nicotine patches for the smoking. They try to get now there's a range of drugs for obesity, and they try to get people to take exercise. In treatment of psychosis, we tend mostly to think about stopping the psychosis. And what I'm suggesting is that we should think about psychosis in the same way that cardiologists think about coronary artery disease. Or maybe we should even go further than the cardiologists. So one can think that, that coming back to what are the causes involved in psychosis, on one side there's a genetic predisposition to schizophrenia, and on the other side there's a genetic predisposition to mood disorder, and some people in the middle, schizoaffective people, have a predisposition to both particularly, but there certainly is overlap. But then we've got a range of different causes. Now there are rare organic causes like temporal lobe epilepsy or NMDA receptor antibodies. They are relatively unusual. I'll not say much more about them, but there is the neurodevelopmental pathway to psychosis that we know that in many cases there is impaired neurodevelopment. Then there is drug-induced psychosis, and particularly there is stimulant abuse and cannabis use. I think in Turkey you probably have both here. And then there's also a social adversity pathway to psychosis. Then, of course, we have people who start off with an affective psychosis, either bipolar or depression, and if that's badly treated, like somebody who has several manic episodes, and each time he gets more grandiose and more paranoid, eventually these paranoid beliefs may get hardwired into his cortex. And he has psychotic episodes thereafter. And then, of course, there are, in ladies, there are hormonal causes. That the time when ladies are most likely to go psychotic is postpartum, but also after the menopause, there is also an increase in risk. So if we think of the main three types, there's the neurodevelopmental pathway, and that may be secondary to obstetric events. That it's not difficult to see that as the baby's cortex is developing, if the baby is premature or mother has an illness, then as the interneurons are all getting wired up, some impairment as a consequence of mother's illness or hypoxia can cause some damage to the interconnections. Then we know also that there are copy number variants that I've talked about all the little genes that can contribute together to cause psychosis, but also there are sometimes mutations, and the best one you'll know about is the deletion on 22q11, the DeGeorge syndrome. And something very interesting about it is that if you have the deletion there, then you have an increased risk of schizophrenia. But if you have a duplication, so instead of having 2 copies, you have 3 copies, then you're significantly less likely to develop psychosis than the general population. So it seems to be that there's a difference between a deletion and a duplication with the normal in the middle. So these people tend to have they have a particular pattern of poor premorbid function. They often have minor physical anomalies, often have abnormal soft signs, more likely to have brain structural abnormalities, more likely to have negative symptoms and neuropsychological deficits, and they have a worse outcome with excess of treatment resistance. If you look at people with treatment resistance, they have more copy number variants, and they have more people who have suffered from obstetric complications. So here is just an example. This is a 19-year-old male art student who was born at 27 weeks. His birth weight was 939 grams. He didn't breathe spontaneously. He needed mechanical ventilation, and you can see that he has bilateral periventricular hemorrhage on his ventricles are far too big because he had bleeding into the tissue around them. See, look here, and he was not as bright, not as clever as his brothers and sisters. He was a bit odd. He didn't play well with other children. He sort of got by. One thing he was good at was at art, and he went to art college. But when he was at art college, he started noticing coincidences. Music seemed to refer to him personally. He wasn't sleeping. He was irritable. He believed his college tutor was the devil. He thought that birds were talking about him. So he obviously had increased salience, didn't he? And the birds could tell that there was a force inside him, and he became convinced that the Beatles were coming back to save the world via him. So he is somebody whose the predominant etiology was this insult that he had early in life. Now here's a different group of patients, those patients where they go psychotic secondary to social adversity. Some social adversity provokes the psychosis. And Jim van Os and his colleagues in Holland have done a lot of work on this. But these individuals are more likely to have had childhood trauma. And we know that being exposed to childhood trauma increases the risk of all psychosis, including psychosis. We know that migration increases the risk of psychosis. I guess that you're very familiar here in Turkey with the story of Syrians who maybe their house was destroyed, their family were killed. They tried to get to Europe. They paid some smugglers money or they paid money to try and get into Turkey or into Greece, and they went on rubber dinghies that sank. It was very traumatic, and eventually they get to Europe, and they may eventually, for example, get to Germany or to the UK. And what do they find when they get there? They find that the native population doesn't want them. So they suffer all these traumas on the way, and then they're discriminated against when they get them. So no wonder they have an increased risk of psychosis. Then, of course, adverse life events. You all know that if your boyfriend leaves you, or your mother dies, or your wife dies, you're more likely you suffer a loss, and you're more likely to get depressed. But if you're beaten up in the street, or if you're burgled, or if you're bullied, these are intrusive events, you're more likely to develop psychosis. So the treatment for this group clearly is quite different from the neurodevelopmental patients. Well, maybe that cognitive remediation would be important for many of them, or social skills would be important as well as an antipsychotic. But for this group, they were often anxious or depressed long before they went psychotic. So an antidepressant may be useful, and cognitive behavior therapy may be useful as well. This is our professor of CBT, Emmanuel Peters at the Institute of Psychiatry, and they're doing, it used to be they just did CBT in everybody, CBT for psychosis in everybody, but they now particularly focus on those people who had trauma. So it's obviously much more relevant to give CBT for people who were traumatized than for people who have a neurodevelopmental problem. And then the other group to talk about a little bit today, and I'm going to talk more about tomorrow, is those with drug-induced psychosis. And in the West, I think the first publication of amphetamine psychosis was from our hospital in 1956, but the Japanese had written about it for about 10 years earlier, that too much amphetamine can cause you to develop a psychosis. Not just amphetamine, but more particularly methamphetamine, which is a much more nasty drug than amphetamine. We have relatively little methamphetamine in the UK. Our problem is particularly cannabis. And again, I'll talk about this more tomorrow, but the people who develop psychosis, which is drug-induced, they don't, generally speaking, have developmental problems. So they're not people like the neurodevelopmental people. They were doing as well as their brothers and sisters, and perhaps better than their brothers and sisters. They were good at sports, they had lots of friends, so many friends that their friends introduced them to a drug dealer when they were 12 or 13. Then they were clever enough to conceal the fact they were taking cannabis from their parents. So they have higher premorbid IQ, they have better premorbid function, they have an earlier onset. So people who take cannabis in the UK have an onset about 6 years earlier than people who don't take cannabis. They have more positive symptoms and few negative symptoms, and they have a worse outcome if they continue to use. So this is just a meta-analysis by one of our students, Tabia Schooler, and she showed that in this summary article, if you continue to take cannabis use after the onset of psychosis, you have higher relapse rates, longer hospital admissions, and more severe positive symptoms than for individuals who discontinue cannabis and for those who are non-users. So the best are those people who used to use cannabis and then stopped. Then there are the people who never used cannabis, and the worst are those who continue to use cannabis. Now, in many countries, in the UK in particular, this group fall between the different services. That the people with the psychosis services, they will treat the acute psychosis and then they discharge the patient home. If the patient goes back to using cannabis, the psychosis services get annoyed, shout at the patient and say there's no point in coming here or taking antipsychotics if you're taking drugs as well. And they discharge the patients. And the patients stop taking their antipsychotic and they relapse. Or alternatively, the patient may present to the drug services, and the drug services say, no, we're only interested in heroin and cocaine use. We're not interested in cannabis. And anyway, you're psychotic, so you should go to the psychosis services. So in many places, nobody looks after these patients, which is a pity because the chances are you can make them a lot better. So it's important to think about these people. First of all, you have to remember it's quite difficult to give up cannabis. Cannabis induces quite a heavy dependence. So if you admit somebody with abuse of cannabis to hospital, they shouldn't be able to get cannabis in the hospital ward, so they will suffer withdrawal. And this will exacerbate their psychosis. So what we do is that we cover the period of withdrawal with a drug called Sativex, which is a mixture of THC, the active ingredient of cannabis, and CBD, cannabidiol, which is in some way the opposite of THC. And so we give the patients this while they're withdrawing from the psychosis. And this helps them both to withdraw, and we also keep giving them it initially when they're discharged home, because it helps to prevent them going back to the cannabis. And of course, patients, at least in the UK, are usually taking tobacco as well. So we have to cover their tobacco withdrawal symptoms with nicotine replacement. And one thing which is worth remembering is if you have a patient who is abusing drugs and is psychotic, patients who are drug abusers have low dopamine. And we then give them a dopamine blocker to try and stop their hallucinations affecting in the associative striatum, but we also affect the dopamine levels in their ventral striatum, so they have no dopamine. And when they have that, they get a great craving. So they want to take more drugs. So if you give something like risperidone or haloperidol, you will exacerbate their craving. So it's much better to use a drug which has a lesser effect on dopamine. The best one is actually clozapine, but quetiapine or olanzapine are also better than the strong D2 blockers. So we now have a clinic for people who are the first clinic in Britain for people who are psychotic secondary to using cannabis. And this is developed by my wife, Marta De Forti, who you can see here. And this is called the Cannabis Clinic for Psychosis. And you can see over here, here are these miserable, they're mostly men. They're very miserable, they're smoking their cannabis, their brains are full of cannabis, they're intoxicated. And one of the things about cannabis is it hangs around. If you or I go out and get drunk tonight, in 24 hours the alcohol will mostly disappear. We go out and smoke cannabis, it'll still be detected in a month. So it has prolonged effects on the brain, and these people, they're miserable and psychotic, and they go to the cannabis clinic, and you can see the transformation, can you? You can see that here they are, they're cheerful, they're taking exercise, they're learning to play the guitar, they're reading books, and they've got a girlfriend. So this is a wonderful thing, this clinic. No, we can't promise this on the National Health Service, but sometimes it happens. So these people are very worthwhile, the effort. So over 15 to 20 weeks, they attend a weekly peer group and one-to-one meetings, and they get daily text reminders of their goals. And if they keep clear of cannabis and their urine is clean, then they get vouchers for Amazon or for a supermarket or whatever they want. So patients do very well at this clinic. So this is the money spent per week. This is in pounds.
We have lost 5 minutes, I think.
So this is the money spent per week, going from nearly £80 a week down to an average of £20. And you can see from every day that at baseline, at the end point, only 20% are smoking every day. So this clinic has been a great success, and actually we got quite a lot of publicity for it. This is the Sunday Times of a couple of years ago. Now with the clinic, I'm looking at my life in a whole different way. My brain is starting to think again. I'm doing an apprenticeship that's changed my life. So let me just conclude. Once we treat psychosis with D2 blockers, our job is only beginning. We need to treat the causes of the psychosis. Now, I have shown you idealized subtypes, a neurodevelopmental type, a cannabis type, a social adversity type. Now, of course, sometimes more than one risk factor is involved. As in coronary artery disease, more than one risk factor is involved. But the principle remains the same. Each cause needs to be addressed, as well as addressing the psychosis with antipsychotics. So thank you for listening.